Is Raman Sharma, faculty at Sinai, and glad to be here today. So we're going to start with something that's it should be something that is really well ingrained in the initial steps of every case that you guys tackle or will be tackling in the future. Pretty much how should you decide your Guidewire choice? What is the algorithm, and how will you tackle these complex cases? I'm a consultant for Abbott. So what exactly is your Guidewire algorithm? There are a tremendous amount of factors that will be playing whenever you do choose your initial Guidewire, or how you do change your Guidewires throughout cases. And this comes down to specific factors that are involved in the architecture of the actual Guidewires, and then also details that are specific to the patient themselves. And these include the wire design, what is the core of the tip, what's the characteristics of the plaque, what axis do you have, what's the length, what working length do you have, and we'll briefly touch on all of these as well. So in regards to the actual guide wires, we see that there are about 6 or so building blocks that we'll say are very relevant towards 3 basic core concepts of the actual wire itself. They're related to the core, the coating, and the tip. So your core diameter we'll again speak about will be very important. The coating of the actual wire, the material that the wire is actually constructed of, and what's happening at the tip. The coils or the covers of the actual wire as well, and then also what's happening at the tip in terms of what is coating the tapered portion of it. And each of these specific components, you'll see, will then allow you to decide when to use each one. The technical attributes that do change with this will be ones that will give you more support, like your CTO crossing wires, your flexibility that will be used for crossing, subtotal lesions, and then also will also relay, especially when you come out to talking about the core material. What is the response on your end when you're torquing, when you're twisting? What is happening inside the body? So that's like the torqueability. So all of these things then finally result in what the important outcome is how do these wires perform? And we'll be talking about that as well. So in your labs, whenever you guys are done with your training and you guys go into the field and start to supply your lab or go into some academic institution and want to have your wires, the wires you have to choose for will be ones that are your workhorse wires and ones that are your specialty wires. Your workhorse wires should be soft, should have an atraumatic tip. They should have a very good tactile feedback to get you to where you actually want to be, should you need to change to some sort of a specialty tip. So a Spartacore run through, things like that, things that will not cause damage, that you'll be able to bring to your lesion of complexity and exchange should you have to. And these should be cheap, they should be versatile, and they should really get the job done. And this is where the majority of your cases will begin and hopefully even end. Now, should you get into more complex cases, then that's when you have to then decide to transition to a specialty tip. And the specialty tip is where you really start to venture out into the different worlds. Do you need a wire that has a very high tip load? Do you need a wire that's very, very durable or has a very, very tapered tip that's also hydrophilically coated? So these interplays will then decide which ones you will be working with in the long term when you get to that point that you have to change. So the first thing we're going to talk about is tip load. Tip load is pretty much what is the amount of load to deflect the tip of the wire when it's held at 10 millimeters from the tip, just to make it bend 2 millimeters, as you see on this diagram on the right. Higher tip loads obviously will be better for CTO lesions that need to be penetrated. And it's not always just the use of a high tip load wire that is something that should be a part of your armamentarium, because even a wire that has a lower tip load can be given a higher tip load by just the adjunctive devices that you use. Should you choose to use a transit catheter or a guide extension catheter, these things can increase, off-label the actual tip load that is provided to the lesion. So all these things should be taken into consideration when you're deciding the wire of your choice. So tip load translates into this other concept of penetration power. There's a mathematical formula if you really care for it. And what this basically means is that the tip load is translating to the physical surface area of the tip of the wire. This is a concept that if you choose to incorporate into your practice I'm sure will help guide your choices. But just remember that it's a high tip load wire is also translated into the diameter of the wire that you choose. The simplest way to just think about it. So a 014 wire versus an 035 wire, they have an inherent difference, not just because of the tip load, but because of just the diameter. So these two things should be something that you actually are also thinking about when you're choosing your wire, whenever it comes down to when you're going to be choosing for a particular type of crossing. The type of crossing, whether it's subintimal or true intimal, and we'll talk about that as well. So the three platforms that we will work with in our field, and I don't think any of you will be able to work with a different one. There's an 025 platform that there are not many devices available for it, but you have 035s, 018, 014. Iliacs are largely 035. For iliac CTOs, it's not uncommon to start with an 014 and then up to a 035. SFAs, you can kind of use all of them. It just depends on what is the lesion that you're trying to tackle. And below the knee, the tibia vessels, 014, 018, those are pretty much going to be your go-tos just because of the fact that an 035 may cause more harm. Because remember, the diameter of the wire itself can translate to a tip load. So then increasing amounts of dissection risk, and again, the working length also becomes an issue as well. So when you choose, we'll just briefly talk about this, and then we'll talk about some more stuff afterwards regarding the individual wires. In the iliac system, the 035 wires, we know that they are very durable. It's the working length is not really much of an issue considering where you're going to be getting access from. And all of the working devices that we use for the iliacs, almost all of them besides Shockwave, are 035 compatible. So that's one thing that is really favoring 035 use for the iliac system. For the SFAs, we have things that are for pretty much every single system. The 035s are very useful when it comes down to physically getting up and over. If you have to do pullback gradients, we have the straight tip catheters that can actually be used over an 035 system to do your pullback gradients, as well as your balloons and your stents are almost universally over the 035. There are some more specialty stent systems that are actually over the 014, 018. But then when you get to your very complex lesions, that's when we should be considering, let's transition from your 035 system to your 014, 018. And this will allow you to use your specialty tip wires. So remember, you have your workhorse wires and then your specialty tip. And your 014, 018s are the beginning of that transition. So going from your run through Spartacores or whatever you have as your workhorse wire in your lab, transitioning from that point is where we begin to really work. And these wires that we use in our labs, remember, the working length is one very, very important thing to always consider, because we have a lot of coronary cases that we also do in our labs, and if you have to make sure you use a wire that is simply just long enough. So what about the actual lesion helps you choose which wire you're going to begin with? So the first question is whether you have a stenosis or whether you have an occlusion. The goal for a stenosis is not to make it worse. So if you have a stenosis, it would be ideal if you can avoid a dissection, cross the lesion intimately, and then from there provide your subsequent final therapies. Occlusions can also can differ in their morphology. You can have a long, very, very long lesion as entirely occluded. We see this very, very often where you have a proximal SFA CTO that reconstitutes in the early P1 segment, or you can have lesions that throughout the course have small focal lesions of reconstitutions and full occlusions. So When crossing occlusive lesions, your question should then be, do I start with the idea that I want to cross the entire thing subintimally, or do I want to really try to cross intimally? And each of these wires, there are specific characteristics of the wire that you want to go with. If you want to start with the stenotic lesion and you want to avoid dissections, you want something that has a tapered tip, something that is hydrophilic, that will find the true subintimal channel. Because remember, a lot of these stenotic lesions, even some of the occlusive lesions, actually have small microchannels that will actually allow your wire to make it through. So you need something that has a durable body. You need something that has a hydrophilic tip. You need something that has possibly even a tapered hydrophilic tip. Now, when you go for the occlusive morphologies of the plaques, if you want to go with a subintimal crossing, in our lab, one of the upfront ways, depending on the length of it, assuming if we have one of these SFA CTOs that I was mentioning, crossing subintimally is usually the first way. And we use all of our imaging modalities to help us cross back at the reconstitution point to then recross into the intima. But again, you need something that will make your way into the actual subintimal space, and then allow you to take a small knuckle all the way through. Now, remember, when you're crossing with subintimally, you have to make sure you have some sort of transit catheter to kind of help make sure that you have a very small knuckle, because the more you dissect, the more problems you can really create. So with a transit catheter, you can keep this knuckle that you'll be taking all the way down very small. And just like if you were talking about a very stenotic lesion versus a CTO lesion that we want to cross intimally, true luminal, you want a very hydrophilic tip, tapered tip, and that's if there are small microchannels. If there are no small microchannels, then we're talking about trying to make sure that we have a very, very high tip load. Now we're talking about our CTO wires, a Confianza, Asahi, Astado, things like that. So these complex lesions, again, remember that there are a lot of different factors that will have you choose one wire over the other. Branches, the morphology of the actual plaque, the morphology of the proximal cap, the morphology of the distal cap, the length of it. All these things will play a very critical role in having you choose which wire you're going to be using. I'm sure everybody here knows the CTOP classifications, and basically all this concept is just entertaining, is that there are morphologies that are consistently seen in our CTOs that predict success and predict failure. So in cases where you have a CTOP classification, where you have this second and third one, where you don't have a clear proximal cap, these are very challenging to address, because you can imagine if you have the ones that have the U at your proximal tip, your wire will want to go into the actual lesion and help cross the true intimally. But if you have ones where you're deflected towards the side, then you have to worry about crossing subintimally, going to branches, and your wires will then also change. So these different classifications will also help you decide what your upfront wire will be when you decide to choose. So it's not unreasonable to say that if you have a particular CTO that has a concave versus a convex, to base your wire choice off of that. So how do you use these wires now? So pretty much what you can do is that you have different types of techniques. This is, again, remember, this is our long wires, depending on the lesion of the lesion length, how far in the actual leg it is. That will translate to what you do with your hands all the way down to where the lesion actually is. But the concepts are still kind of the same. So you have drilling that could be done with both your workhorse wires as well as specialty wires. We'll see this primarily with your CTO wires. And you have to be able to, the key here is you have to be able to engage the true cap. You can't try to just haphazardly push these wires down. These wires are very, very high risk to dissect and make a lesion that's probably smaller, much longer. Sliding through, again, you have to be able to believe that your lesion itself has a characteristic that will allow these small microchannels. So you can confirm these kinds of features with prolonged DSA imaging, taking a microcatheter down to the lesion and then taking a picture instead of, if you don't want to use too much contrast. But you have to really try to confirm that this wire will be successful here if you see these. If you do a DSA image with a microcatheter at the level of the lesion and you see absolutely nothing, a hydrophilic tip wire is really not the wire to begin with at this level. The penetration and tapping is kind of similar to the drilling technique. The concept is still the same. You have to be able to engage the tip. So if you don't have any small microchannel that you see and you want just to try to penetrate through it, the technique is similar to drilling, but it's still the same concept that you're trying to go physically through the true lumen through this plaque. And then the subintimal dissections, again, taking a knuckle with a hydrophilic wire with a strong support body and taking it all the way through the intimal and then re-entering at the distal reconstitution. So again, just to talk about this in summary again, so we have the stenosis and the occlusions, and stenosis, you don't want to dissect further. You want to cross as intimately as possible. You want to limit the amount of dissection you create proximally or distally, and you want something that will respond very, very well to what you're doing in your hands. For the occlusions, again, it would be nice to cross luminally. It's not something that happens very often, but it's deciding upfront based off the lesion characteristics and the morphologies and the length. It's not unreasonable, nor is it incorrect to switch to a subintimal strategy up front. So the wires that we'll see for the stenosis, things, again, that have a hydrophilic tip and your workhorse wires or your command run through these. These are just the ones that are in our lab. So I'm sure you guys have a large armamentarium of similar wires. So just the concepts of workhorse wires, hydrophilic tip. And when it comes down to crossing true occlusive lesions versus subintimally, the wires we're talking about, again, are the hydrophilic tips. If you see a microchannel, if you, again, so I really want to reiterate this one very simple point. If you take a picture, you do not see any lesion, any small microchannel, even the faintest of microchannels, going up front with a hydrophilic tip wire is not going to get you anywhere. You're just going to use a wire, you're going to bang up the tip, and then you're going to switch to another wire afterwards. So it's really important to really understand the morphology of a lesion when you choose your wire, when you're transitioning from your workhorse wire to your next wire. So if you don't see anything, wires that have a higher tip load, wires that have a stronger body, to then switch to a different technique, as not trying to find the small microchannel, but then going for a penetrating drilling technique with your with Confianza, Astato, and all those things as well. And then if you want to go subintimally, then again, going with your hydrophilic wires, then create a small dissection flap and take that all the way down. And also very important is that these techniques can be interchanged. Not all morphologies of the lesions will be consistent throughout the entire way. You'll have lesions where you want to cross subintimally that may be followed with a highly stenotic lesion, in which case you would then want to convert to trying to go within the true lumen. So we very quickly spoke about a lot of different factors that will play when it comes down to your wire choice. The wire design, again, the main things you want to think about are the core, the diameter, and the tip. And this translates to which lesions it will be most effective on, which then leads to having to think about what is the characteristics of the actual lesion. What's the plaque type? Is there a channel? Is it long? Is it calcified? And finally, the final thing which you guys should always think about is, what is my second to last destination therapy? What is my atherectomy of choice? What is my treatment of choice? And what are the platforms available on this wire choice? So if you have a atherectomy system that is 014 compatible, but you manage to cross with the 035, you can't atherectomize unless you change. So things that you have to consider. If you want to deploy a supera stent, you can't do it over your 035 system. So you have to then change again to 014, 018. So again, just there's a lot. Oh, there it is. So lesion, location, strategy. A quick word about your aortic, your iliac tortuosities. It's not uncommon that just how you can increase a wire's tip load, you can lose its torqueability and steerability with very tortuous iliacs. So that should be something you also just keep in the back of your mind, that sometimes not just so straightforward. The wire that should be your workhorse wire may be absolutely useless for some reason, and if you see that, you should consider, is there something that's happening in the iliacs that's taking away from its steerability. So again, there are a tremendous amount of wires available to everybody in every lab. I don't know which ones you guys are working with, but all your labs will have workhorse wires. All your labs will have specialty wires. It's up to you to make sure you choose the right wires. And again, it just come down to just the wire characteristics and then as well the lesion characteristics. Thank you.